I'm going to start off by talking about epilepsy, which includes a heterogeneous group of pathologic disorders which have in common the presenting symptom of seizures. This is a chronic condition. Someone who has a one-time seizure does not carry the diagnosis of epilepsy. And epilepsy affects approximately 1% of the U.S. population. If you remember, there are two main types of seizures: generalized and partial seizures, and on imaging we're mainly looking at patients who have the partial type of seizures. In the generalized seizures we see diffuse abnormal cortical electrical activity, and in patients that have partial seizures they have focal abnormal electrical activity. And the most common one that we're seeing on imaging is the complex partial seizure, which means that the patient has some loss of consciousness. Up to 40% of patients will have intractable epilepsy, which means they're no longer responding to medication and they become candidates for surgery. The seizure focus is most commonly found in the temporal lobe, and the frontal lobe is the next most common location, and therefore we spend extra time on imaging getting high-resolution thin sections through the frontal temporal region. The role of MRI in the epilepsy workup is to detect a structural lesion, which we will find in about 25% of patients. It has the highest anatomic resolution, and it's used to help plan the surgery. We have to remember that in about 20% of patients we will find dual pathology, so when you see one lesion, we always have to continue to look for another one. The MRI data will be combined with the scalp video EEG. Patients will also undergo neuropsychological testing, a WADA test, and SPECT and PET studies in certain cases. You take a look at this MRI in which we see a normal brain, no abnormal signal abnormalities or atrophy, but yet when we see this interictal SPECT, which means it's being performed in between seizures, we see that there's a very large area of hypometabolism, so there's a large area of functional abnormality. In those cases where the non-invasive criteria is discordant, whether the MRI is negative or the EEG is non-localizing, or we see more than one lesion on MRI, the patient will go to the OR and have intraoperative placement of subdural grids and electrodes, as we see here, these hypointense areas along the cerebral hemisphere. And on occasion, we may see depth electrodes protruding into the brain parenchyma to help pinpoint where the seizure focus is, because the surgeons never want to take out an area of a brain unless they're fairly confident that the seizures are arising from that area. At NYU, our seizure protocol differs based on whether the patient has a new onset seizure versus someone who has someone being followed for recurrent epilepsy. In adults, someone who presents with a first-time seizure, we do a routine brain with contrast. We include axial gradient echo T2 star images and diffusion-weighted imaging. In patients where we have already performed the initial study, we know that there's not a tumor, we will do these cases without contrast. We'll include high-resolution coronal T2 and FLAIR images. We orient the coronal slices in a perpendicular fashion to the long axis of the hippocampus. We also include a coronal 3D T1 weighted volume of the entire brain, looking at the cortex and gradient echo images. In the pediatric population, we will do a routine brain, but we'll also include the high-resolution coronal images so as not to miss any cortical abnormalities. And CT essentially has no role except in those patients who cannot have an MRI, they have a pacemaker, or in the case where we're emergently looking for a hemorrhage. Here's our MRI protocol. We see sagittal T1, gradient echo T2 star images, T2 weighted images. We have our 1.5 millimeter thick coronal T1 weighted images through the entire brain, and we carefully look at the cortex, compare side to side. It's not always so easy to find the cortical abnormalities, but we try. And here are the coronal FLAIR and T2 weighted images through the frontotemporal region. And when we compare the sides of the brain, we always want to make sure that we're comparing the same side. And occasionally the patients are tilted, so you can use some of this normal anatomy in the inner ear. Here we see the normal fluid in the cochlea or the vestibule, or you could use the internal auditory canals as a basis for comparison to make sure you're comparing the same sides of the brain. Okay, we're going to start off by reviewing some of the pertinent anatomy in patients who are being evaluated for seizures. I'm going to start anteriorly. You see this gray matter structure is the amygdala. See that on either side. As we move posteriorly, the amygdala is anterior and superior to the hippocampal head. We're starting to see some of the temporal horn. We see this little CSF cleft in between the amygdala and the hippocampus. The hippocampal head has a characteristic contour. There's an undulating superior surface, and it's the largest part of the hippocampus. As we move more posteriorly, we see that the hippocampus, we're getting into the body, becomes a little smaller, and the contour is smoother. Above the hippocampal body, we see this little triangular piece of gray matter, which is the caudate tail, which will merge with the amygdala. More posteriorly, the hippocampal tail becomes smaller, and we're also seeing the crura of the fornices and the edge of the hippocampus. Let's take a look at the neocortex. This is the normal 6-layered cortex, the temporal lobe. If you take a look at the white matter interdigitating in between the cortex, we have the superior temporal gyrus, the middle, and the inferior temporal gyrus. The next named gyrus is the fusiform gyrus, and the most medial gyrus is the parahippocampal gyrus. Take a look at the hippocampus, which is composed of Ammon's horn and the dentate gyrus. If we look at this microscopic section, we see that these neuronal cell bodies are in, and we look at the schematic representation, we see CA1, 2, 3, 4, which interdigitates with the dentate gyrus. On MRI, here we have what's the transitional cortex from neocortex into the hippocampus, which is 3-layered cortex. This is the subiculum, and we're guesstimating where CA1, 2, 3, and 4 might be, and the dentate gyrus. It's also important to know that there's normal white matter above this gray matter, and there is some interspersed white matter in the hippocampus, but this is the efferent white matter pathway of the hippocampus, which is the alveus, the fimbria, and that will eventually form the fornix. The normal hippocampus on FLAIR images may have some ill-defined high signal intensity, and this has been studied in a paper in radiology to show that, in fact, it is true, that you may see some increased signal intensity. It should not be focal. Even other areas of the limbic brain may have high signal intensity, and this may be thought to be due to the fact that it's a 3-layered cortex. There may be increased water content and increased capillary density. Okay, I'm going to review some of the most common pathologic substrates that we will see in patients with who have seizures. The most common entity that we will see on imaging is hippocampal or mesial temporal sclerosis, also called Ammon's horn sclerosis. The next most common entity that we'll find are patients with cerebral neoplasms. We'll also, if you see a lot of cases, you'll find vascular malformations, developmental anomalies. Anything that causes gliosis, whether it's trauma or surgery, can cause the patient to have surgery, and infectious and inflammatory disorders. Mesial temporal sclerosis is an entity in which there is loss of neurons and gliosis, primarily affecting the CA1 or cornu ammonis, the first portion of Ammon's horn, also called summer sector. The pathogenesis of Ammon's horn sclerosis or mesial temporal sclerosis is that there's an early insult in the first years of life. The child may have febrile convulsions or anoxia, and there is evidence on histology that there is some neurogenesis occurring at this time. There's a latency period up to about the 10th year where the patient may or may not have a seizure, but they're responding to medication. And then at a mean age of 34, these patients are no longer responding to medicine because there's so much gliosis and neuronal loss. And we see these patients at imaging because they're preoperative candidates. So the diagnosis is made based on clinical, specific clinical seizure type, EEG findings, and imaging features. So this is really plays an important role in making the diagnosis. What do we see? Most common findings are atrophy of the hippocampus and abnormal high signal intensity on T2 weighted and FLAIR imaging. So this is seen in the majority of patients. What else can we find? Since there is atrophy, we see dilatation of the adjacent temporal horn. The fornix is the efferent white matter pathway, so that can be atrophic, and that connects to the mammillary body. And here we see atrophy of the ipsilateral fornix and mammillary body. Also, we can see atrophy of the collateral white matter. This is another little sign that's better seen on T1 weighted images, but if you compare the white matter on the right side to the left side, you can see that it's atrophic. We can see increased signal on the amygdala or increased signal anywhere in the temporal lobe because there are many interconnections between the hippocampus and the adjacent temporal cortex. Here's a patient who has a temporal lobe seizures on EEG, and if we compare the hippocampus on the right to the left, we see that the left is severely atrophic. There's dilatation of the temporal horn. This patient's a little tilted. We see a piece of the amygdala. If you look at the collateral white matter, which is the most medial white matter strip on the right compared to the left, you see that the left collateral white matter is also atrophic. And on the T2 weighted images, we see what we expect to find: abnormal high signal intensity within the hippocampus, and the same is on the FLAIR images: abnormal high signal intensity, dilatation of the temporal horn. The standard treatment for patients with mesial temporal sclerosis is anterior temporal lobectomy, where they resect the anterior temporal lobe and the majority of the hippocampus and portions of the amygdala. And these patients do very well postoperatively. 80 to 90% of patients will either be seizure-free or greatly reduced number of seizures. Now here's a case where the findings aren't so definitive. If you compare the right to the left hippocampus, and you may say that you see that the right hippocampus is smaller than the left. You don't see any increase in size of the temporal horn, and no real increased signal intensity. And on the FLAIR images, you're sort of trying to decide whether there is abnormal increased signal intensity. Perhaps there's a little atrophy. And the T1 weighted images, these thin section 1.5 millimeter thick sections, are actually very useful to get a better look at the anatomy. And in fact, you may come to the conclusion that there is hippocampal atrophy on the right side. So is this mesial temporal sclerosis? Well, in fact, it may not be, and in many cases it isn't. Patients with seizure foci in other parts of the brain, whether it's the frontal or parietal lobes, may have hippocampal atrophy as an incidental finding because of all the numerous limbic interconnections. So if you just see hippocampal atrophy, we at NYU generally just report that as hippocampal atrophy rather than giving the patient the diagnosis of mesial temporal sclerosis, because often it's not. And what is the lateralizing sensitivity of spectroscopy in mesial temporal sclerosis? Well, it's very good. It's about 80%, but you have to remember that you may see bilateral abnormalities in about 30% of patients. So if we place the voxel over the abnormal hippocampus, we see decrease in the NAA, N-acetyl aspartate, marker of normal neurons, and that makes sense because in mesial temporal sclerosis we have neuronal loss and gliosis. In patients who are postdictal, you may also see lactate. So this is a patient with a new onset seizure, and if you compare side to side, the first thing that may strike you is the dilated temporal horn, but if you look at the contralateral side, you see that the hippocampus and the amygdala are enlarged. There's subtle high signal intensity within the medial temporal lobe structures, and we certainly would give contrast in this case. So certainly, in this case, in this situation, certainly this would not be a case of mesial temporal sclerosis because there's abnormal enlargement. So our first thought is to exclude something like an encephalitis. Clinically, the patient has no symptoms of herpes type encephalitis, so we can start to think of other things such as a low-grade glioma. On contrast imaging, I'm not showing you that slice, but there was no contrast enhancement. And you may say, well, could this be a hamartoma? Well, you really shouldn't see enlargement of these structures. So we'd certainly do short-term follow-up. As we've done in this patient, we follow this patient very carefully. And this patient hasn't gone to the OR to resect this area because this is eloquent brain. The medial temporal lobe structures control memory, and in certain patients you may see a very severe memory deficit if we were just to remove the hippocampus and adjacent structures. There's another patient with a new onset seizure. If you look at the right medial temporal lobe, we see that there's abnormal low signal intensity. On post-contrast images, we see some peripheral enhancement. And on the T2-weighted images, you see a very well circumscribed lesion with no adjacent edema. And on the FLAIR axial images, if you take a look, there's no real distortion of the anatomy. The sulcus is preserved on the right as compared to the left side. The temporal horn is not effaced. So this is pretty typical of some of the temporal lobe lesions that you will find in young patients. This one turned out to be a ganglioglioma, but the DNET, dysembryoplastic neuroepithelial tumor, will look very similar. They can have associated mesial temporal sclerosis with the lesion. They're usually superficial. They can be calcified. A low-grade astrocytoma can also look very similar, and the pleomorphic xanthroastrocytoma. These are all lesions that we think of when we see particularly a young patient with seizures. And here's a patient an older patient with a new onset seizure. We see a typical extraaxial mass. There are vessels draping over the lesions. On the T2-weighted images, we see intermediate signal intensity. There's a significant amount of edema and compression. And on post-contrast, we see fairly homogeneous enhancement with a dural tail. So this was a patient with a meningioma with a new onset seizure. The most common neoplasm that we'll find in patients over the age of 50 is metastasis. So we always give contrast to these patients. If you take a look, there are multiple subcortical lesions which are enhancing in various ways, homogeneous sort of rim enhancement, and they may or may not have edema depending upon the size of the lesion. So of the 4 types of vascular malformations, the cavernous malformation and the AVM are the ones that are going to present clinically, usually with hemorrhage, and the patient may have seizures. The capillary telangiectasia and developmental venous anomaly are usually clinically silent. So cavernous malformations are what we find most often in a younger patient population with a new onset seizure, and sometimes you follow these. They are frequently surgical lesions, except when we see them as so large and in significant portions of the brain. Here we see the typical mulberry type of configuration, areas of high signal intensity on the T1 weighted images, representing subacute blood products. And on the T2 weighted images, we see a circumferential rim of low signal, evidence of hemosiderin. This one has a very large cyst associated with it. There's a lot of compression of the brain. And it's important to always do the gradient echo T2 star images to look for other foci, because frequently we will see multiple other lesions. If you take a look at this large one, you see that there's low signal in the periphery of the lesion. On this case, there's no edema, but we know that previously this lesion must have bled. And these are also found frequently in the periventricular region and within the subcortical white matter. Familial patterns have been reported in about 10 to 15% of patients, and this is autosomal dominant in transmission. And these seizures are thought to arise from the irritative effects of hemosiderin, gliosis, and compression of the adjacent cortex. It can also develop cavernous malformations after radiation therapy. Here's another patient who had new onset seizures. If you take a look at the brain, there are multiple areas where you see heterogeneous signal intensity. Most of these, here's one in the cortex, here's one in the suprasellar cistern, so you may see them in unusual locations. Here's another one in the brainstem, infiltrating the superior cerebellar peduncle. This is a pre-contrast T1 weighted image. We see some stippled high signal intensity, what we'd expect to see in a cavernous malformation, the subacute blood products. And on post-contrast images, we see some ill-defined enhancement. And the gradient echo images really help us to make the diagnosis, where we see really low signal intensity of the entire lesion. Here's another patient with a new onset seizure. And this one's not as clear cut, but we do see a well-circumscribed lesion within the temporal lobe. There's a small area of low signal intensity, and we suspect that it's either calcification or blood products. And if you look at the temporal horn adjacent to it, it's actually dilated. Post-contrast images show some minimal peripheral enhancement. So you might think of a cavernous malformation. On the gradient echo images, which I'm not showing you, there was no circumferential rim. So you have to think of other diagnoses. This could be, as we said before, a ganglioglioma, a dysembryoplastic neuroepithelial tumor, or a low-grade astrocytoma. And this one turned out to be a ganglioglioma. Developmental anomalies are another one of the entities that we're looking for when we're evaluating MRI of a patient with seizures. And this includes a large group of disorders which have in common disruption in the formation of the normal six-layered cortex. So in any of these stages, whether it's proliferation, migration, or organization of the gray matter. The most common entity that we will actually be able to detect is cortical dysplasia. And in the pre-MRI surgical series, this was thought to represent a small proportion of patients with epilepsy, but now that we're doing MRI in practically all patients, we're seeing that this is actually much more common than we thought, particularly in children. So in this case, it's a very obvious abnormal brain. We see diffuse cortical thickening and some evidence of sulcal formation. So in this smooth type of brain, this is in the spectrum of a lissencephaly, but we see some sulcation, so this would be an incomplete type of lissencephaly. These patients generally do not do well clinically. But here are some of the findings in some of the cases where it may not be so obvious. What do we look for? We'll look for cortical thickening, what's been described as this cortical dimple. You see the infolding of the gray matter and a large sulcus. Also, if you carefully look, you see these curvilinear low signal intensity lesions. So it's also been demonstrated that patients with cortical abnormalities have abnormal venous drainage associated with them frequently. And it's really important that when you find one lesion to always look at the contralateral brain. Because as you see in this case, there's abnormal, fairly large area of thickening in the contralateral hemisphere in multifocal regions. Here's another patient that was followed for many years with a negative or normal MRI of the brain. If you take a look at the right side compared to the left, where you see the normal gray-white matter differentiation, see that in the left frontal region, there's loss of that normal distinction on the FLAIR and the T2 weighted images, and this is also usually very well seen on the T1 weighted images. In this patient, there was a lot of motion artifact, but this is another important sign to look for, which is blurring of the gray-white matter differentiation. Here's a transmantle type of cortical dysplasia where we see gray matter in the white, where we shouldn't see it in the white matter, and it extends from the ventricular surface all the way to the cortex. And we see this little dimple from the ventricular margin, so we have to always be suspicious when you see this sign of schizencephaly. But in this case, we weren't able to detect it. It may be a very closed type of lip schizencephaly. And in less than 5% of cases, you may see calcification of a cortical dysplasia. Here, this is the post-contrast T1 weighted image, but on the pre-contrast, it was also similar. You see high signal intensity within an abnormally thickened gyrus, and on the gradient echo images, we see abnormal low signal intensity. And this has been reported to be associated with patients who have CMV in utero, a calcified type of cortical dysplasia. In this case, again, we see that cortical dimple, the outpouching of the ventricle on the left, and we see abnormal gray matter. And in here, we will find a gray matter line cleft, which extends from the ependable to the pial surface. And here's a more obvious open lip type of schizencephaly in this patient. Again, we see gray matter lining this cleft, and always look at the contralateral hemisphere, because you will frequently find abnormality in the other side. If we look at the left frontal lobe, there's also diffuse, there's a very abnormal thickening and loss of that normal gray-white matter differentiation. Patient also had agenesis of the corpus callosum with an associated pericallosal lipoma. Here's the another end. These patients may sometimes do very well clinically and just have this patient with a new onset seizure. But if you take a look at the ventricles, you see that there's gray matter lining the ventricular margin. We always want to make sure that it's isointense to gray matter on all pulse sequences, on the T2, on the FLAIR images, it's the same signal as the cortex. And on post-contrast images, we see no enhancement. Because some tumors may also look very similar, such as lymphoma can have intermediate signal intensity, but so you always want to give contrast in these cases. So let's compare that to a patient who has these type of subependymal nodules. If you look at the signal characteristics of these nodules, they're not isointense to cortex. Some are lower in signal intensity, others aren't, so we suspect that they're calcified rather than blood products. And if you look at other regions of the brain, you see multifocal areas of abnormal high signal intensity in the gray matter, within the white matter, and on post-contrast images, we see these large enhancing lesions within the foramen of Monro. So we know with the constellation of findings, this patient has tuberous sclerosis, and these larger lesions at the foramen of Monro are likely giant cell astrocytomas. These can be followed. We just want to make sure the patient doesn't develop hydrocephalus, because these are low-grade type of lesions. And the subependymal nodules that we see here are hamartomatous lesions. Tuberous sclerosis is one of the phacomatoses, in which there are dysplastic stem cells in the germinal zones which result in disorganized collections of dysplastic glia in neurons. And as we saw, you could see cortical hamartomas, white matter lesions, and subependymal nodules, which are hamartomas, and they are frequently calcified. And on the clinical triad, these patients have mental retardation, epilepsy, and skin lesions. Here's the history of a young patient with gelastic seizures. We know these are the laughing type of seizures. If you look at the brain, we see a large mass protruding from the hypothalamus into the suprasellar cistern. And we always want to give contrast, and we see that there's no evidence of contrast enhancement in this patient, so we make the diagnosis of hamartoma of the tuber cinereum. Frequently, the patients will also have precocious puberty, and you may sometimes see a very large pituitary gland, and this hamartoma is just heterotopic normal neuronal tissue. And here are the FLAIR and T2 weighted images of that patient, in which you could see that this mass just has sort of an intermediate signal intensity. This is a patient who had previous trauma. If you look at the frontal lobe, we see that there's abnormal high signal intensity within the cortex, there's atrophy, and the gradient echo images show that there's curvilinear low signal intensity. So there's evidence of a prior hemorrhagic contusion. It's important to detect the hemorrhage because sometimes this can be resectable in patients who have really severe seizures. And it's been shown in studies that patients who have hemorrhagic contusions are more likely to develop epilepsy than patients who have non-hemorrhagic contusions. If you look carefully, you see multifocal, other areas of abnormal low signal intensity, evidence of other hemorrhages. So this is a patient with trauma, cortical contusion, and we see gliosis and hemosiderin. Here's another patient who had epilepsy. It's a young patient. If you take a look at the periventricular white matter, posteriorly, you see that there's severe atrophy, left greater than right. And so what is the diagnosis? Well, when we see periventricular white matter atrophy, you certainly want to think of periventricular leukomalacia. And it can be asymmetric like this, and you may be saying, well, where's the lesion? Well, in patients who have periventricular leukomalacia, they frequently develop epilepsy. And there's certainly not much the surgeon can do for these patients, but you're making the diagnosis. Infections can also cause a patient to have seizures. Here we have a patient who has a lesion in the subcortical region with a lot of edema surrounding it. On post-contrast images, we see rim enhancement, and on the diffusion-weighted images, we see high signal intensity, evidence of restricted diffusion. So these diffusion-weighted images actually help us in strongly suggesting a pyogenic abscess. And if you look lower down in the brain in the same patient, you can see that there's evidence of other lesions. Here we have one which looks like it's sort of cavitary, there's some volume loss, there's abnormal high signal intensity, it's probably gliosis, and there's no enhancement. So this is a treated lesion, and on the diffusion-weighted images, we see that there is no evidence, it's not restricted. So this is a treated pyogenic abscess, and here we have a new one. In a case like this, where we see bilateral, symmetric, high signal intensity, primarily involving the medial temporal lobes, we always want to think about herpes encephalitis first and last. And on the post-contrast images, you may or may not see enhancement, but these patients really have to be treated aggressively, as we all know. Here's another example of encephalitis, and you may say, someone may ask, well, why couldn't this be an infarct? Which is frequently brought up when you discuss these cases. Well, if you take a look at what's involved, we see that there are multiple vascular territories that are abnormally involved in this patient. We have evidence of the middle cerebral artery, the posterior cerebral artery, which is the inferior temporal lobe, and the medial temporal lobe, which is supplied by anterior choroidal. So, and in addition, we have frontal lobe involvement. So whenever you see a lesion that doesn't follow vascular territories, you always have to think of encephalitis. And on post-contrast images, again, we see some ill-defined enhancement, evidence of active encephalitis. And in this case, we see chronic encephalomalacia. This is the cavitary, chronic form that we're imaging this patient months or years out after encephalitis. And this is an example of use of diffusion imaging, particularly in patients who have had status epilepticus. They're seizing for over 30 minutes. You may see areas of actual ischemia, so it's important to detect that, where if you look at the diffusion-weighted images, you see multifocal small areas of cortical increased signal intensity, evidence of restricted diffusion. So in conclusion, patients with epilepsy should be evaluated by a dedicated MRI seizure protocol. The primary role of MRI remains to define structural lesion. And in the future, functional MRI will certainly play a greater role in the preoperative evaluation of these patients. Thank you for your attention.